I am really excited today to be interviewing Courtney Bancroft. Dr. Bancroft is a licensed psychologist with a private practice in New York City, specializing in insomnia treatment and sleep wellness. She also holds a position as the director of a postdoctoral fellowship in primary care psychology at a large hospital in the Bronx. Let's see. There she teaches postdoctoral fellows, medical residents, and psychology externs on topics related to health psychology, primary care psychology, and social justice. Additionally, Courtney holds leadership positions on the boards of early career psychology and organizational consulting divisions of the New York State Psychological Association. Dr. Bancroft completed her clinical internship at Yale University and a specialty postdoctoral fellowship in health psychology and primary care at the Yale VA Connecticut Healthcare System. She has a master's degree from Loyola University of Maryland and graduated from Pepperdine University with her PsyD in 2014. Her writings and commentary on sleep have been featured in a variety of media outlets and podcasts, and she conducts seminars and workshops for organizations who are hoping to learn more about sleep for their company wellness approaches and employees. Dr. Bancroft strongly values the idea of a client-centered, holistic approach and the importance of presence, compassion, and understanding when working with clients and organizations. And I can say firsthand, I know you walk that walk because we've worked together, and I'm just so pleased that my students get to learn from you today because you bring such wonderful things. So, I guess we're going to focus a lot today on your work with people who struggle with their sleep. How did you first become interested in that?
Thank you. And thank you for the introduction, Dr. Ruddy. What I was doing in my postdoc was working with people who had addiction issues or who were having health psychology related issues. And it was my first time in the primary care world. And in that world, I saw so often people coming in with sleep issues. And the primary care docs were handling it as best as they could, but utilizing medications and things like that. And it was in this postdoc that I had the opportunity to do a training where I could become certified in cognitive behavioral therapy for insomnia, which is kind of like a new treatment around that time in 2014, 2015. So I, thought this could be really helpful, especially with all the sleep issues that I'm seeing in primary care. And I don't really know too much about it. So I became interested in it. I did the training and I got the certificate. And one of the things that really stuck out to me about CBT for insomnia or helping people with insomnia in this therapeutic approach was just how quickly you saw results. And, in general, psychotherapy is wonderful and you really see results, but it takes a long time. And so for this to have such quick results, even within like 6 weeks, turnaround, somebody's insomnia who had insomnia for 60 years was just incredible to me. And the impact that it made on people's lives and hearing their testimonials to say, wow, it really, really changed my sleep and also my health. And so I started to really get interested in and become so much more aware of the association of sleep and health and sleep and mental health. And once I realized this, it was just this whole new world that kind of opened up for me. And it was really, really interesting.
I mean, it sounds like part of what you really enjoy about it is you feel like you're able to be really impactful for people and really improve their quality of life, their mental health and their physical health and their sleep. And so I can see where that's pretty compelling, and it's such a common problem. You mentioned a certificate. Can you say more about the training that you got?
Sure. So this was a training that was essentially 3 or 4 full days long that we did by certified instructors of cognitive behavioral therapy for insomnia. And we did this training, with them, reviewing all of the literature, a manual, practicing, doing role plays. And then from there, we had 6 months where we had to see patients and record our sessions. And then those were sent out to professional coders who would code how much we were doing CBTI and whether we passed that. We also had to run 2 rounds of 6-week group treatment. So it was about a 6-month process. And at the end, we were able to receive a certificate if we had completed that with like individual cases and with group to the extent that they were looking for. And the thing about CBTI is it's very data driven. So even the training you can see is like very data driven, and with these raters, rating you on how competent you are to do the therapy.
I mean, it sounds like a great way. I love when you get down to that raw data of your actual interaction with people and giving that kind of feedback of like, here's how you could have been even better. And I appreciate that rigorousness. You know, I think we're all looking to do the best that we can, and to have that kind of feedback and to know that you've passed a bar is pretty powerful stuff. And that was part of your postdoc, right?
Yeah, it was part of my postdoc, but it was kind of this independent thing that you had to apply for. And they only had a certain number of slots to do
Mhm.
because they had these trainers who were coming in. And I think, you know, it was a great opportunity within postdoc because the VA that I was working for was actually able to pay those fees for you.
Wow.
You can definitely seek this independent training and certification as well. But if you're part of a program, you can kind of like ask your program to see if they would be willing to you know, cover that cost for you while you're still a trainee. So I definitely recommend doing that.
Yeah, those kind of certifications go a long way. I think it's really reassuring to patients, and it also allows you then, when you, if you are looking for a new position or within your own position, to develop a service to say, look, I bring this specialized expertise. It gives you a certain credibility that you don't have without those kind of things. So, so you mentioned primary care, and I know you work in primary care, but who all do you tend to collaborate with as you're helping people with their sleep issues?
So it's really interesting, and just like a little bit about my training journey was that I actually trained as a full-time clinical psychologist in my training. Never really had a primary care specialty until later on, when my expertise in addiction brought me into that work. And so I was very familiar with doing like independent one-on-one individual sessions and a lot of psychotherapy. And so when I decided, as a supplement to my full-time job, right as I became early career, a psychologist, I decided to open up a private practice. And so when I did this, I went about it in a traditional way, and I started to, you know, market to my psychology colleagues and talk to various psychiatrists even and things like that, and market to the general consumer. What was really interesting that came up around this question of who you tend to collaborate with was that my phone did not ring off the hook at the beginning. And everyone was really surprised because they're like, wow, so many people struggle with sleep. You know, I would expect that you would have so many referrals. But it was because I wasn't collaborating with the right people. And what you see as a consumer, if you don't know about cognitive behavioral therapy for insomnia, which is simply talk therapy, you go to medication. And who prescribes medication are MDs and doctors. So the people that I collaborate with the most are actually, you know, different primary care facilities, you know, different clinics, independent clinics, or private practitioners in who are physicians who are general primary care. And these are the people that get all of the individuals coming to them around sleep. I need help, I need medication. And if the practitioner is knowledgeable about cognitive behavioral therapy for insomnia, they'll actually refer and they'll need practitioners. So that's where the majority of my referrals would come from, especially at the beginning. It was around 2016 that the American Medical Journal started to label CBTI as the gold standard treatment. And so this shift in the medical culture from prescribing to now offering CBTI as the frontline gold standard treatment happened more publicly. And it was really then that you saw these practitioners being like, oh yeah, I know what that is. But also offering little free talks to different agencies that are MD focused or psychiatry, because these are the people that are usually getting these referrals around prescribing. And so usually when I set up a relationship with a client, I'll ask them if they want me to be able to get in touch with or collaborate with their primary care physician or their psychiatrist around medication if they are planning on stopping medication. And those are typically the people that I collaborate with the most. Maybe there's a sleep study that was done by a sleep clinic, and so I would get that information from them as well.
Yeah, I mean, it sounds like what you're saying is when people can't sleep, they go to their doctor for a prescription for a sleep aid. And not that long ago, that was pretty normative, but there's really been a push against sleep aids. And I guess, you know, I don't know that my students know a lot about sleep aids and what their efficacy is. What do they actually do for people? So the stat I always tell people is I think they add something like 11 minutes or 12 minutes of sleep. It's like this tiny little amount. Can you just kind of educate our group about sleep aids and how we should talk to them about them with people?
Yeah, absolutely. So, the thing about sleep aids is that there actually is not one on the market that helps to, um, that's for long-term use. Let me put it that way. So there are different, medications on the market that help for short-term sleep aid help. Like, let's say it's a month of struggling or 2 months or 3 months. Most of them are not actually studied beyond 3 months. And so they are not supposed to be used in any long-term capacity. And yet they're the only things on the market. And so these are the things that doctors were turning to for a really long time. So you have somebody on Ambien, let's say, for many, many years, and eventually the consequences of these medications far outweigh the benefits. And you'll actually see doctors saying, I need to get this patient off. They're older, they're on another medicine that's conflicting. This could cause a lot of problems. I really need to get them off. Some of the other medications that are used outside of like the sleep aid category are often, basically sedatives that help to reduce, the anxiety levels of people to help them fall asleep, or that just kind of knock you out and sedate you. And when we look at the sleep quality for people on these sedatives, it's not the same type
Yeah.
of sleep quality that you would get in natural sleeping patterns. So it's not mimicking that. It's actually just sedating you. And this can cause some long-term damage because when you are not getting the correct type of restorative sleep and your brain is actually in a sedated mode, you're missing out on a lot of really good sleep. The other thing about it is that there's tends to be a psychological dependency over time. And so the person starts to believe that they cannot sleep without the medication. And yet they're still suffering. They're not necessarily fixing the sleep problem. Probably 9 out of 10 people who are on the medication long term just aren't, they're still not sleeping well, but they feel that this psychological dependency has to maintain. And so it can cause a lot of difficulty from a behavioral standpoint that this medication is kind of like part of the routine, even though it isn't even necessarily helping.
Yeah, I mean, I think that's a great example of how perception kind of comes into things and how the complexity of something that seems like, sleep is so complex.
Mhm.
The impact of not having it, the impact of not having good sleep, the tendency and all the thoughts and feelings that go along with not being able to sleep. It's just really a powerful thing. And unfortunately, I'm guessing by the time people come to you very frequently, they're already on a sleep aid. They were already been through years of this, and you're really trying to get them to go back to basics. So in terms of the kind of people that get referred to you, tell me more. What are kind of common scenarios or common underlying issues that make people begin in the first place to have sleep issues?
It's a great question, and it's kind of different for every person, which is why, when I get a call from like a magazine or somebody and they're like, what's the number one tip for sleeping well? There really is no answer. If there was an answer, we would all do it and that would be solved, right?
Right.
But so it's
And you'd
more
be on your yacht in the Caribbean. You'd have
exactly
marketed that and you'd be all done.
right.
It'd be great.
But it's more like the way I think about it is a more like a recipe that works for every individual person. And the reason for that is that the causes of sleep issues are a little bit varied, but they come together in a pretty, particular way. For most people, I would say it's some sort of stress and
Mhm.
it's some sort of heightened arousal drive, if you want to think about it that way, in the sense of like fight or flight system. And whether that's because you're just a type A person, whether that's because you are trying to do your best at work, whether that's because you just had a new child and you're trying to be a really good, mom or whatever. These are the types of people that come in and they're just really worried about their sleep. And usually it's a stressor that causes it, but then it translates into sleep anxiety is what I kind of call it, where
Mhm.
you have a couple of bad nights of sleep and then you start to say, oh my God, something's really wrong with my sleep. I better fix the sleep. And the sleep itself activates the arousal drive and the cycle goes on and on.
Mhm.
So arousal drive is a big thing. And then there are some things, like life cycle events. So, after having a new baby, a lot of times people will be on heightened alert and then they can't really get rid of that feeling around bedtime. Maybe it gets paired around bedtime. People who kind of get off schedule and then just like can't get back onto schedule. Sometimes you see people who are going through menopause. This can be really disruptive to your temperature regulation. And since temperature regulation has a lot to do with sleep, We often hear a lot of difficulty around this. And just anybody who's kind of like lost their faith in their ability to sleep, you see quite often, whether that's because of their job, whether that's because of, just life circumstances. If they feel like they've lost confidence in how to sleep, they often become, really worried about that.
Well, and I think that whole concept of regulation, disruption, circadian rhythm, it's the idea of balance. And I think so much of health is about balance, right? And so the idea that sleep would be one more place where balance really matters, and one more place where any kind of dysregulation is likely to result in issues with the quality and quantity of your sleep. And then, like you said, kind of off to the races people go when they start having these kind of issues, because their thinking and their feelings about it start to exacerbate every aspect of it. So, so you mentioned that you oftentimes are able within 6 sessions or so to be helpful to people. Do you think that's a pretty typical course, or can you say more about what happens from the moment somebody contacts you till they get to a point of no longer needing your assistance?
Yeah, definitely. So I usually tell people 5 to 7 just because there's a little bit of variation. And then I also let people know that I'm a provider who's pretty transparent about what the course will look like. And we'll continuously check in
Mhm,
with data about how many more sessions are needed,
mhm,
and what things remain. So when somebody comes to me, typically I'll offer, a quick 15-minute free consultation call, make sure that just from a screening perspective, this seems like something that would work for them before they spend time and money and investment in coming in.
mhm.
And then from there, hear a little bit about, the trajectory. I might ask a couple of screening questions about whether they've ever had a sleep study done or things like that as well. And you don't need to have a sleep study done to come in, but it's helpful information if they have. And
And
how
for
the
the uninitiated, can you just say what a sleep study is? I'm not sure
Oh,
everybody knows what
sure.
it is.
Yeah. So typically, when I'm saying sleep study, it means like a polysomnography type of study that's done at a sleep clinic or with a kit that you send home and attach to you. So this is like studied by sleep scientists from a physiological standpoint, where they're looking at brain waves, they're looking at oxygen levels, and ruling out some of these physiological conditions that can be interrupting sleep. And that's one thing that even if somebody doesn't have a sleep study, I would do with them through certain measures. So I would rule out some restless leg syndrome. I would rule out sleep apnea. I would try with like a validated measure to rule out a circadian rhythm disorder or a REM disorder. And I would also rule in or out and measure mood, because sleep so often can cause mood difficulties or mimic that. So usually when somebody comes in, if I'm using a PHQ-9, which is a validated measure to measure mood, they're going to become positive on it. I'm not going to diagnose them with depression, because what I do after 5 or 6 sessions is I remeasure it. And typically with the resolving of the sleep difficulties, that score goes down. So I usually take it at the beginning and the end, and I let them know this as well, so that if I do take it at the end and they are still positive for maybe a mood disorder, then we talk about other options, and they can stay on in therapy with me. They can, see another therapist who's maybe like in network or whatever the problem might be there. And so we can work through that. So after we do a full intake session with a lot of these different measures, and I hear very, strategically about their sleep and create a conceptualization plan, it's from there that I can kind of guess which sessions and modules do we want to address first, which might help them heal in a very efficacious and quick way. It's a terrible business model from a private practice standpoint, because of how quickly people heal, right? Because you're getting patients in, they're finished, and then they usually are done. But so yeah, typically around 6 sessions, and it's usually around session 3 that you really start to see some results. It's after session 1, that's really the intake, that you get a baseline. And so session 2 begins the intervention piece. One of the hardest things is just like knowing that once they get over this hump, if you will, of the 3rd or 4th session, they're going to feel a lot better. But it's really hard to know somebody has to still suffer at the beginning there until we implement the intervention. But so I just explain that usually up front.
Yeah. And it sounds like being able to have that predictive and that expectation setting for people is really important too. I mean, you hit on something that I think is really important, which is how often do you feel like the presenting concern is sleep, but then ultimately as you go through your protocol, you find that that's the tip of the iceberg, so to speak?
Yeah, it's a great question. I tend to think about the first session as not just including, information about the person's sleep, but also about their life. It's so important to know what it's like to get to know this person and like what it's like to be them in the world,
Right.
and to get to know what stresses them out, what's going on in their relationships, what's their family like, what role do they play in the family, what type of thoughts keep them up at night, what types of experiences or life cycle stage are they in right now. And so we incorporate all of that. We make sure to address those things as they pertain to sleep, but
Mhm.
also we talk about how the tools learned in CBT can be generalized out. And so I
Right.
say, if there is a thought, a distressing thought that comes up, but it's not about sleep and it's actually about, your relationship, you can use this tool in that way. And
Exactly.
so many people really like that because they're getting more for their money, if you will, of like being able to expand that out, and utilize these tools later on. I think for the most part, sleep is usually not the thing that causes the sleep issue to begin with, if that makes any sense. Like,
Mhm.
usually there's some sort of stressor or event or life change that happens. And then the sleep becomes, or the anxiety about the sleep comes secondary to that. So,
Right.
what we work on is we reduce that anxiety around sleep. And then we also talk about ways to handle general stress and understand that sleep will ebb and flow in quality and quantity during stressful times. And so we can use these tools to kind of address some of those things out of there as well. And we do, I do make sure to screen for like bipolar or PTSD on those initial sessions. And if I feel like, okay, I think that your sleep issue is actually because you may have undiagnosed bipolar disorder, we make sure to address that or talk with somebody else, or uncover that. Same thing with PTSD, because many times people can't sleep because of the nightmares that are a symptom of PTSD. But if that's the case, we want to identify that. If we identify those, we may or may not continue with a course of CBTI, but we want to do that with the recommended guidelines around how to work with those types of issues. And so I'll usually let people know upfront and make recommendations for an overall treatment plan for them.
Well, and I appreciate what you just said, because I do think sometimes people hear CBTI or a protocolized treatment and they think that you end up doing a one size fits all kind of plan. So what I really appreciate what you just said is that you've got to contextualize people, right? You've got to understand, see it through their eyes, understand their family and stress situation, their history, what else might be going on for them, and that there still may be aspects of CBTI that will be helpful to this individual, and then also determine whether or not they need to go see somebody for some work through some trauma or to work through some family relationships. And I'm guessing, like you said, it's not uncommon that whatever the initial stressor was that led to the disruption that got them out of sync may have resolved, but now they're out of sync and they can't get back to that place of balance or feeling like they have, kind of the ability to have that natural sleep that we all want. And it's not lost on me at all that you're in New York City too, which is like the, home of insomnia. So all that context matters, right?
Yeah. And in marketing the practice too, that was the fun part of it, where you could, I think my website says like, in the city that never sleeps, become someone who does, right? Because you can put in like what it's like to be a New Yorker. And if I'm licensed in New York, I want to know what that lifestyle is like for many people. And for many people, it's go, 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 right? Your bars and your clubs are open until 4 a.m. on the weekend. It's work hard, play hard. It's, the city of, everything being open and lights and noises and a lot of stimuli. So it's really an interesting piece when you're thinking about who you're marketing to and your demographic. You want to really make sure to include some of that, which will draw in people that are like, oh, that's me, that's my
Right.
lifestyle, I could really relate to this.
Right. When you talked about over arousal, which is, the New York City experience is over
Yeah.
arousal, but I also, implicit in what you just said is normalizing
Yeah.
and educating and making people feel like there's not something wrong with them, not pathologizing. Can you say a little bit about how you pull out strengths and resilience to draw on those? Because I know you well enough to know that's a big part of how you work.
Yeah, no, that's a great point. And so, thank you for bringing that up as well, this normalizing. one of the things that I kind of like pride myself in is I'm like a secret cheerleader of hope, if you will. And when that patient comes to me, I want to let them know that like we're going to do everything possible to make sure that they get sleep, that there is hope. I let them know the statistics about CBTI, that, you know, over 80% effective. Here are the reasons why I really am passionate about this treatment because of this, you know, and let's talk about what you value and how you can bring more of that in. So for example, I had a woman who was so, you know, worried because she kept gaining a lot of weight and all of this stuff. And she wanted to sleep because she knew that sleep and stress around sleep and lack of sleep can actually cause weight gain. And so, you know, it was like a really important thing to her because she was in this period of going through menopause and was ending, you know, postmenopausal, and she, you know, just felt not like herself. And so
Right.
by helping her with her sleep, we were also able to then get her to a plan where she could, you know, work out more often. And she just felt so much more like herself. And it was helpful for me to know her values in
Mhm.
working with her. And so that's a really big key component. And then normalization. And
Right.
you even see, I often will get an email after our first session. I ask them to create a sleep diary, well, not create, but fill out a sleep diary that I send to them and get baseline data. And probably like 3 out of 5 times people will email me back and say, hey, Dr. Bancroft, I did the sleep diary, but like my sleep was a little bit better this week, so I'm not sure, should I be? And it's just because of that human connection, having somebody named an expert in this area telling them it's going to be okay, that is healing, right? And so
Oh,
letting them know like this is normal, like still, you know, let's still work on it, because once that feeling goes away, you may still have a lot of these things coming up because we haven't quite untangled them yet or done any intervention
right.
officially. But that human connection, that normalization is super important.
There's data about how once people make the phone call to have a therapy appointment, they get better, right? I mean, it's all about, and I think it's also, it's such a big step for people to do that. I think sometimes we forget. That's huge that somebody finally said, okay, this is it. Today's the day. I'm going to make that call. I'm going to make that appointment. And so, and you mentioned about, you know, intervening in a way that has staying power. How often would you say you see people coming back like 6, 12 months later, they've kind of fallen back into issues? Or do you feel like once people learn these skills, they seem to be able to carry forward pretty well?
Great question. I really like, I hit this home with them when I say goodbye to them. We create a relapse prevention plan that's tailored to them, of which things worked. They help co-create that. And then they have it. And I say, keep it in your like dresser drawer. And if, you know, these things, and at the bottom it says, if anything comes up, you can always, you know, contact me for a
Right.
refresher session. But I always say to them, I hope I never see you again in the nicest way possible, because, you know, you have these tools, you understand these skills now, and you are now the master and in control of your own sleep. And so I would say that before the pandemic, I had never seen anyone come back. Pandemic, people were saying, you know, I'm really stressed. Can I just talk to you? And maybe it was one appointment. Typically, I think I saw like 3 or 4 people for one refresher appointment.
Okay.
And really, it wasn't even about sleep. It was just like, wow, it's really stressful right now to live in New York, and it's really difficult. And you know, had a good relationship with you, and I want to
Yeah.
just talk to somebody.
Yeah.
So we made plans for them to either like talk to other therapists or continue in a regular therapy role, that kind of thing. Or maybe they just need a little bit of a reminder, like they have these tools, let's review what they are, let's review the relapse prevention plan. And that has proven helpful.
Well, a lot of what we're talking about in our class is the importance of reserving specialty mental health for people who truly need it and using kind of minimum effective dose, right? So to what degree do we do what we do and send people out into the world with those skills and hope that they're able to do well? And if they are struggle, to know that they can always come back, because the need is so massive. And it sounds like with COVID particularly, you're really seeing uptick in levels of distress. And again, it's that idea of disruption and overstimulation. And that's what we're living right now, right?
Definitely. Right.
Yeah.
And when it was first happening, the barrage of news and all these things. And like right now, even with the election being like the coverage being on like late at night, they usually have the debates, the RNC, the DNC are happening late into the night. And it really disturbs people's sleep just because of the level of activation.
Yeah.
So, you know, loneliness, all sorts of things people are seeing. But yeah, when it comes to checking in with them and making sure we're giving that like minimum effective dose, that's one of the things I tell them straight off the bat. I say, we are going to be in clear communication. We're going to be looking at data each session that you provide to me about how you're sleeping. And once we reach a certain level from a clinical, like a evaluative standpoint, we will make sure that I let you know that. And then you lead me in how much more you feel like you need. So we do this measure called the Insomnia Severity Index each week. And once we get to a level of a score that highlights no insomnia, I let them know. And I say, like, congratulations, officially, as of your score today, you do not have insomnia anymore. I have these fancy little spreadsheets and things that produce beautiful graphs, which usually go in like a beautiful trend. And I show them these. And then we talk about, like, what do you feel like you need? And they say, well, this could be a fluke. This could just be 1 week that maybe I should meet with you again, but maybe I should do 2 weeks so that I get 2 weeks worth of data that I can sleep, or maybe once a month or something like that. So really let them lead for those last couple of sessions. And usually once their brain kind of is able to say, I have enough data to say, wait, I am doing this, it's not just a fluke, it wasn't just a good week, then that's when they really feel confident to go forward.
Well, and I also just want to highlight the degree to which you're really doing evidence-based care, right? And having those touch points. And people like to see the data. It's very reassuring to them. Like, oh my gosh, I can actually see the trend line. I can actually, and I think especially with sleep, they to your point, they just feel so much better when they get good sleep. It's kind of irrefutable. It's like, here's the data, but oh, by the way, I can concentrate and I'm not whoopy and all that good stuff. So.
Yeah.
This
and
has
to your
been
point, just really quickly, the narrative around sleep is so important. So I usually bring in a little bit of that type of therapy as well. And yeah, in CBT, it's called like your thoughts and your beliefs and everything, but also there's a narrative around sleep. Somebody asks you about your sleep, you tell them, oh, I'm a light sleeper. I'm a great sleeper. I'm a terrible sleeper, right? And these narratives stick with us throughout and across our lifespan. And what happens is so amazing, because even when we start to see the data show us that they're really improving their sleep, their narrative stays behind, and they say, no, I'm not a good sleeper. And I have to show them the data and say, actually, look at this. This is your data. You told me this, these
right.
things, right? Like, you have really improved. So the data is so important in this treatment in particular because of that. And it helps a person really believe and, get in touch with trusting their own body and their own progress, which is not so easy for us sometimes.
And that narrative and identity, I think, is true in lots of things, right? Oh, I'm just a depressed person.
Right.
Oh, I've always been an anxious bear. Oh,
Yeah.
I'm just not a good sleeper. Oh, I'm not healthy. That's what people always bring to us. And so again, I think it's really interesting because, again, I do think sometimes people think of CBT as something that's very, I not warm and fuzzy, but you know what I mean? Like, just kind of like this, talk about how you think and how you feel. And really, if you don't do all the other parts, if you don't do the contextualization, if you don't pull out the narrative, if you don't understand the person's dynamic situation within their family and their system, everything they're up against in their lives, you're not going to be successful. So I think I really appreciate you saying, look, CBTI is the jam. The data is amazing. And there's certain core things that we do, but we pick what we do based on what I hear from this person. And a lot of it is helping them redefine themselves and their relationship with sleep. So I think that's pretty powerful. Anything else you want this group to know about being somebody who focuses on this, life as a psychologist? Here's your moment.
Yeah. One of the things that really helped me was when I was trying to decide about private practice. I read this book that was more business focused because I just never really got any business education in school. And I was like, wait, I'm opening a business. This is going to be something new. I should read about this. So I read this book and it said, make 3 columns and list the things that you're really good at or certified in or have specialty areas in, the things you really like doing, and then the need of the market. So what do you need? And whatever is across all 3 of those can be your specialty.
Right.
And that's really how I found this specialty and decided to move forward with it as a private practice, because I just noticed the need. I noticed I had a specialty certification, and then also that I really liked it. I really liked this, and I felt a little more confident as an early career psychologist because I did have this certificate, and I did, have a little bit of a confidence confidence boost around like, okay, well, I may not have to do too much emergency type of work in private practice, or have a lot of those issues that can be really scary when opening it. So finding something that you're passionate about that kind of spans across all those columns can be really helpful. And then just like reading and learning about marketing and how to put yourself out there in the world can be a helpful addition as well. And thinking about the problem, whatever you're working with, from a cultural context too, because like sleep, there is such an interesting culture around sleep in our country. Sleep plus technology, the changes that we've seen over decades around sleep patterns of Americans and also other cultures, and how that relates to work. And there's like so much to learn there and to understand, like from a social justice perspective, like, wow, you know, this might really affect certain populations, or, you know, this toxic kind of work culture and things like that can be really interesting. And then from understanding that, I've been able to kind of branch out and talk to organizations. I was able to recently give like a talk to hundreds of people at the UN about sleep and about, you know, how it affects us and how it can help us to improve, and different ways to do that. And some other like organizations, large and small, who are really interested in this because it can help productivity, it can help better health for their providers or their employees as well. So, you know, thinking about ways in which you can help on an individual scale, but also getting creative in the market and in the field about what other people need can be a great way to start your practice.
Well, and diversify what you do day in, day out, and have a lot of different ways that you feel like you're having an impact. So, and I just want to echo too what you said about social justice. I think very often we know people, you know, if you don't feel safe, are you going to sleep? I don't think so, right? And so I think it's really great that you bring up those realities that some of the people that we serve face, and to always contextualize and always understand the broader context. So thank you so much. This was super helpful.
Thank you.
I will give my students the chance to ask me questions that I might forward to you if I feel
Sure,
like
no problem.
But again, I'm just so grateful. Thank you for your time.
Awesome. Thank you.
Bye-bye.